So my topic is spinal tumors, and it's a pretty vast topic. I don't have any relevant disclosures. Spinal tumors in general are less common when compared to their intracranial counterparts. You see one for every four intracranial tumors. Um, we tend to lump them into three categories. One is the cord, the spinal cord itself, which we call the intramedullary tumors, and then the surrounding meninges and the nerve sheaths, they give rise to the intradural extramedullary tumor category. And then the final is the extradural category, which is all outside of these, the bones of the spine and etc. About 5 to 10% of these spinal tumors make up the intramedullary tumors, whereas the majority ones tend to be the meninges and the nerve sheath tumors, which are about 50 to 60%. And then pediatric population, you tend to see more of the intramedullary lesions, and adult population, ependymoma is the most common tumor that we tend to see. Presentation in general, patients present with progressive symptoms of scoliosis, weakness, falls, muscle spasms, pain because of involvement of the local spinal cord, nerve roots, and spinothalamic tracts. Evaluation is clinical evaluation, followed by, some people do electrodiagnostic evaluation either through EMG studies or nerve conduction studies. And you can do a radiologic evaluation that brings us to this area where you can evaluate a patient's, spine tumor either through X-ray, CT, bone scan, or MRI. So when it comes to radiology, which is our field, plain radiographs do play a starting role, and then followed by CT, which can show more detailed lytic or sclerotic lesions. It can show osseous remodeling. Then CT myelography is usually reserved for patients, at least in my practice, where they cannot get an MRI scan. Like there is a contraindications, just they have a pacemaker that doesn't allow them, or anything, any other device that doesn't allow them to get an MRI. And MRI is the most sensitive in terms of the resolution. It gives a very good contrast resolution. So in general, plain radiograph CT and CT myelography don't add as much as an MRI does, especially in evaluation of spinal cord tumors. So again, we will see today in three different buckets: cord, the intramedullary ones, the intradural extramedullary ones, and then the extradural ones. And I will be color coding them as well accordingly, like the light violet, greenish, and then light orange. So here's a little cartoon figure of where these three buckets fall into. So that's the cord. Everything with the intramedullary ones are going to be everything within the pia mater. And then we've got the next category, the intradural extramedullary. So it's still within the dura, but it's extramedullary outside the cord. And so this is the green area that I've shaded, consisting of like nerve sheath area and meninges. And then we've got the extradural one. It's like everything outside of the dura, including the bone. So anything that goes to the bone, is going to be lumped into this category. So in terms of the location, so the exact origin of the tumor is going to be from neuroepithelial cells like glial cells, neuronal embryonal cells. That's going to be all of this entire bucket is going to be an intramedullary, right? Or it could be little vessels inside. It could be melanotic origin like melanomas, or it could be lymphomas like lymph cell origin. These are non-neuroepithelial cells. And then you've got non-neoplastic cells, which is not actually a neoplasm. So you can have like cavernous malformation. You can have lipomas within the cord. And then finally, metastasis. So metastasis is a category that falls into every single location. Basically, a malignancy where the tumor cells kind of lose their cohesion. They go through the bloodstream and they get lodged in any part of the body, right? So if they get lodged inside the spinal cord, they become intramedullary. It could be intradural, extramedullary, just in the meninges, like you have leptomeningeal metastasis, and then you can have extradural, like outside, like you can have osseous metastasis, right? So metastasis falls into any of these categories. Then coming to this intradural extramedullary categories, you've got the Schwann cell origin of the nerve roots, right? Then you get arachnoid cap cells within the dura, which can give rise to these meningiomas. You've got dural and PL fibroblasts themselves. They can also give rise to these tumors like meningiomas. These all fall into that central category of intradural extramedullary lesions. And you've got the extradural ones. They can be a primary osseous tumor, like arising from the bone in itself. It could be some notochordal remnants that end up becoming malignancies, or you could have metastasis. Like I said, metastasis can be anywhere. So here are those primary examples, right? The intramedullary neuroepithelial origins, such as glial origins, are going to be ependymomas, astrocytomas. You can have vascular origins, hemangioblastomas from the mesenchymal components, and then ganglioglioma is an example of a mixed, neuronal and glial component. And then Mets everywhere. And then extramedullary, the middle compartment, you can have nerve sheath tumors such as neurofibromas, schwannomas. You can have meningiomas from these arachnoid capsules or within the fibroblasts of the dura. You can have myxopapillary ependymomas and so on. And then the extradural ones, primary osseous tumors. There can be a variety of these primary osseous tumors, like osteoid synostosis. You've got osteoblastomas, osteochondromas, aneurysmal bone cysts, giant cell tumors, osteosarcomas, chondrosarcomas. You can have venous malformation within the bone, osseous venous malformation, also known as hemangiomas. Unfortunately, incorrectly, and then chordomas due to the notochordal remnants, and then Mets, right? So that's the quick gist. Again, our three categories are color coded today. You've got the cord ones, right? Like the intramedullary components. You've got the extramedullary, but still intradural components. And then you've got the extradural components in orange. And I'm going to touch, it's going to be very challenging to cover everything. So I'm going to touch on a few most commonly seen ones in my practice. The intramedullary ones examples are going to be ependymomas, astrocytomas, hemangioblastomas, and gangliogliomas. Intradural, extramedullary, the most commonly seen ones are going to be nerve sheath tumors and meningiomas. Extradural, again, Mets is going to be by far the most common that we encounter. And then we've got the osseous venous malformation, previously known as hemangiomas or misnomer, and then chordomas and all the other primary osseous tumors that we won't have time to cover in depth. Okay, so intramedullary tumors. Now, these ones, again, depending on the cell origin, can be all of these ones we just saw, right? And how do they present? Like on an MRI. So MRI is going to be the mainstay for assessing. The CT may show some expansion, but then when it comes to the actual details, MRI is going to be the primary modality of choice. Now, you see some cord expansion. So because there's a tumor, is going to expand the cord. And then once it breaks down the blood spinal cord barrier, it's going to start showing leakage of contrast, and that shows up as enhancement. In majority of these tumors, there is that breakdown of that barrier, and so there is enhancement. And then there are cysts. You can have cysts within the tumor. You can have cysts outside the tumor. So you can have a tumoral cyst. You can have a non-tumoral cyst. So these, the non-tumoral cysts are like mostly in the poles of the tumor, like, the upper pole or the lower pole of the tumor. They're not covered by tumor. They're just little fluid that just gets trapped. And so they're not lined by tumor. So they don't actually enhance. They don't have that enhancing rim. And then a lot of these tumors tend to have like syrinx as well, because it doesn't let the CSF flow inside the central canal. So again, ependymomas. So ependymomas are kind of popular in the adult age group. And so there are types of ependymomas. There are subependymomas. There used to be these different types. Subependymomas, myxopapillary ependymomas, then grade 2, and anaplastic ependymomas. But now, again, like I said, this is more common in the mid-adult population. Most common is going to be in the cervical region. And 40% of them show up in the phylum terminale, lower down. And that tends to be the myxopapillary ependymoma category. They all have their perivascular pseudo-rosette pattern. They are pretty circumscribed, and they tend to hemorrhage and show necrosis. So they have that very characteristic appearance of blood products that form that hemosiderin cap that's pretty popular for a ependymoma. Here's an example of an ependymoma. There's some edema. Here's the mass in itself. And if you see this dark areas, that dark areas is hemosiderin from constant hemorrhages. So these hemorrhages, eventually the blood products kind of evolve into hemosiderin, and then they get they start depositing over there and form those nice caps for an ependymoma. And here's that expansile appearance and with that edema. This is that resected ependymoma, and here's the histopathological evaluation of it. Now, ependymomas, like I said, they're pretty circumscribed. So when you look on an MRI, how does it appear? So on an MRI, because of the water content of it, it's slightly brighter on T2. And then these tend to have the polar cysts, meaning these little trapped CSF collections typically tends to happen at the poles of the tumor. And then we've got a hemosiderin cap, like I said, and then the edema can result in the central canal dilatation, right, called syringohydromyelia. Now, according to the latest classification, I talked about the prior classification where you had different grades, right? With the new latest WHO classification of CNS tumors, there are three main types. We've got ependymomas with the molecular typing. The latest WHO classification is all about molecular typing. So we've got the MICAN amplification in the when you have that molecular pathology, that's an ependymoma. And then based on the DNA methylation patterns, you've got myxopapillary ependymomas and then the subependymomas. And anaplastic astrocytoma is no longer in the classification scheme used these days. So that's the latest classification, unlike the prior ones. And then all the previous types were just histology-based types, like be that papillary, based on the cell of origin, right? These are no longer in use because they don't have any clinical relevance in terms of like prognosis or like in terms of like treatment management and everything. So here's an example. It's in a 50-year-old female. So here's a beautiful ependymoma. Here's that nice T2 bright edematous lesion. And as you can see, this is all the blood products lined up, forming that nice hemosiderin cap at both the poles of the tumor, right? Upper pole and lower pole. So that's a very classic appearance of an ependymoma. And as you can see, this is a cross-sectional view here on the leftmost side. And as you can see, the tumor, because it arises from that central canal ependymal lining, it tends to be nice and concentric inside, like it's within the cord, it's nice and concentric in the center. So that's a very characteristic feature of an ependymoma. And then, above and below it, there is some edema because it's irritating the adjacent spinal cord. So that's a very nice classic example of an ependymoma. And here's another example of an ependymoma. Again, as you can see, there is some edema. And here on the top, there is a little polar cyst, right? Because the CSF got entrapped there or fluid got entrapped there. That's a polar cyst. And ependymoma, as you can see on the cross section of the very first image, shows a nice central location of the lesion. And here in the bottom, there is that hemosiderin cap that we just talked about because of that hemorrhage, right? It formed a nice cap in the pole. It formed only in the lower pole in this case. And here's some blood spinal cord barrier breakdown, and there's that enhancement associated with the tumor. Okay, here's another example. It's in a 32-year-old male. Patient presented with, symptoms, symptoms of, gait issues. And then we found a nice expansile mass. It was an enhancing mass. And because it's a 32-year-old, slightly on the younger side, people, it was kind of challenging to determine if it was an astrocytoma or ependymoma. And then you can do something called a DTI. It's a tractography tool. So when you do the tractography, it maps out all the tracts within the spinal cord. And as you can see, this tumor actually displaces all the tracts to the side, meaning it's arising from the center. So that kind of helps us differentiate this tumor ependymoma from astrocytoma, which would have actually invaded all these tracts rather than push them away to the side. So that's an advantage that you can have from tractography when you do tractography of spinal cord lesions. So that's a nice example of an ependymoma pushing out the fibers to the side, the tracts to the side. So we saw ependymoma, right? And then another type of ependymoma is the myxopapillary ependymoma. So that tends to occur in the region of the conus and the filum terminale, that from the ependymocytes lining the filum terminale is where these tend to arise. So they're lower down in the cord. They tend to happen in slightly later age group, like third to fifth decades of life, where it's more common in men than in women. And these again are very bright lesions. They also can have cysts and they also bleed and can have hemosiderin. And then these are classified into grade 2 by the recent WHO classification because they tend to recur. So the clinical patterns is there is, it leaves behind some residue and it comes back. These tumors tend to come back and recur. And so they are classified into grade 2. Now, here's an example of a mix-up papillary ependymomas. In general, ependymomas tend to be nicely circumscribed. And as you can see, this is a circumscribed tumor lower down, right? And this was excised, and this is the histopathological examination of it. Here's another example. It's a nice enhancing tumor. If you look on the T2 images, you'll see it's nice and bright. Edematous tumor, right? It's very bright tumor. And again, on a cross-sectional view, as you can imagine, it arises from that central canal and the phylum terminale. And so it's nice and concentric. It's nice and central in location. Here's that enhancing tumor on a post-contrast image. This was in a 30-year-old male. Now, here's another nice example. This one is also an enhancing tumor, right on the right-hand side. It's a post-contrast image. It's a beautiful enhancing tumor lower down in the location of phylum terminale. And on the left-hand side, you can see that it has all these cysts, right? So these are the polar cysts. And as you can see, these polar cysts are not lined by tumors. And so these actually don't show that enhancement because they're not lined by tumor, right? So this is another nice example of a mix-up papillary ependymoma. Then moving on to subependymoma. Now, these are kind of rarer than the ependymomas. They have a more indolent course, but unlike the central location of the ependymoma, these subependymomas tend to be a little more eccentric in location. And these are usually grade 1 tumors. Just a subtotal resection to preserve function has a very good outcome in terms of treatment strategy. These usually enhance, but sometimes they don't enhance. These are also edematous T2 hyperintense tumors. Now, here's an example of a subependymoma. As you can see, it's a nicely elongated tumor. It's extended longitudinally, right? And this is the excised subependymoma. And this is a cartoon view that kind of shows how a tumor has extended superiorly to inferiorly in that spinal cord along the subpial regions, which is why it has that bulbous appearance, but also slightly eccentric in location than the central ependymomas that we see because of the subpial extension. So just below the pia mater, it tends to like expand. And because of that, it also has this classic like bamboo leaf appearance. So that's the appearance that it's referred to because of the way it spreads along the spinal cord. So that's an example of a spinal subependymoma. Now, here's another example. That's the small on the right side is the small enhancing component of this tumor. And remainder of the tumor, as you can see, has that, again, bamboo leaf appearance, tapering towards the end, and then, very expanded in the center and along, a longitudinal extent of the tumor is like pretty long craniocaudally, giving that bamboo leaf appearance. Okay, so we saw so far ependymomas, then we move on to astrocytomas. So astrocytomas tend to happen in the slightly younger population. So it's more common in the pediatric age group, and cervical and thoracic regions tend to be more common in terms of occurrence. Now, astrocytomas have a range of presentations in terms of the pathology. Now, they can be of different grades. You've got the lower grade astrocytomas, grade 1 to grade 3. You've got the lowest grade, the pilocytic astrocytoma, which is grade 1, very good prognosis. And then you've got the higher grade tumors, such as the diffuse astrocytoma. You've got the anaplastic astrocytoma, grade 3. And then you've got glioblastoma, which is grade 4, WHO grade 4. And you've got the histone mutated ones, such as the H3K27M mutation, which is also grade 4 and tends to happen in the spinal cord. It's like its counterpart. It's like the spinal counterpart of the intracranial presentations. And as you can see, there's a range of tumors. So it starts from lower grade. It can be a very high grade, WHO grade 4. Now, astrocytomas, unlike the ependymomas was arising from that central canal. So they were nice and central in location and very concentric. Whereas the astrocytomas, because they can arise from any part of they can be any part of the glia there, they tend to be typically eccentric in location, unlike the ependymomas. Pilocytic astrocytomas are nicely circumscribed, whereas diffuse infiltrative ones are not so much. And with the astrocytomas, you can have little trapped fluid, but because they are within that tumor, they have a tumoral lining, and because of which they tend to enhance on the rim, right? So it's a rim enhancing cyst because it's a tumoral cyst, and they also can present with edema and syringohydromyelia. So this is again that classification scheme. Now, here's an example of a pilocytic astrocytoma, nicely like circumscribed and cystic in appearance. That's a pilocytic astrocytoma, very good prognosis. And this is another example of pilocytic astrocytoma. Here's the enhancing component. It's kind of circumscribed. And then there's a diffuse edema and throughout the inferior aspect of the tumor. And there are some cystic components within the tumor as well. Now, here's an example of a fibrillary astrocytoma. It's a little eccentric than an ependymoma. There's a little bit more spinal cord towards the right patient's left-hand side and then on the right-hand side. So slightly eccentric in location, enhancing tumor. Here's the tumor. There is edema associated, and in this one, it's hard for me to differentiate where exactly the tumor starts and ends. So this is an example of a fibrillary astrocytoma. Now, here's another example of this astrocytoma. It has pretty much occupied the entire cord, if you can see on a cross section. It's in a 45-year-old female, and you can see there are some enhancing components of the tumor, and there's so much edema above and below the tumor. Now, here's another example. It's more located along the dorsal aspect of the cord, right? That's the enhancing component of this tumor, and above and below the cord is a lot of edema associated with it. Now, here's the tumor of that fibrillary astrocytoma on a T2, the edematous appearance of it. Now, this is an elderly female who presented to us, and this was a path-proven grade 3 astrocytoma. As you can see, here is the enhancing component of the tumor, and the patient presented to us with weakness and then was found to have this tumor. And then along the, although astrocytomas initially are more common in the pediatric population, you also tend to see it in the later ages, and this was a grade 3 astrocytoma. And you can see this is the actual astrocytoma with a lot of edema above and below the actual tumor. Here it is in cross section. As you can see, it's more to the side, isn't it? More to the patient's right-hand side. So it's a little eccentric in location than your central ependymomas that you saw earlier. Now, here's a mixed neuronal and glial tumor. This is a ganglioglioma, biopsy proven. And as you can see, it is arising in the brainstem and the upper cervical spinal cord with a lot of cysts at the top, a polar cyst, and also some cystic changes within the tumor in itself. Very expansile mass, initially presented to our pediatric hospital, and now is being followed by an adult in the adult setting, adult care. And then, so those were our glial origin tumors, mixed glial neuronal tumors. And now we move on to hemangioblastomas, which arise from, which are like vascular tumors. They tend to be more dorsal in location. They're very enhancing tumors, very vascular tumors. They have a PL attachment, so they tend to be attached to the PIA, more peripheral in location. They tend to be sporadic and about 75% of the cases, meaning just they originate by themselves. But in people with von Hippel and Dow syndrome, they tend to occur more commonly in the cervical region. These are again very vascular tumors. They are again T2 bright. And then they have this pale vascularity. So it makes it very, which makes the appearance as to having a very tortuous vessel along the peel surface, because they come to supply this tumor. And for the size of the tumor, these tend to have extensive edema. Let me show you a case. So here's a case, right? So this is the tumor. You see how it's like along the pia, it's very close to the pia mater, right? Very and dorsal in location. And if you notice, look at all the vessels that have come to supply this tumor. It's a very vascular tumor, and look at the amount of vascularity. You see all these collaterals coming to supply this tumor. These vessels are nice and engorged, and you can actually see them in this patient. Now, here's another example of a tumor, which is a neuroendocrine tumor. It's not a vascular origin, but it's a paraganglioma, right? It's a neuroendocrine origin. So here's a tumor. These are again like very vascular tumors, as you can see here. Look at all the vascularity associated with the tumor. This is in the region of the cauda equina nerve roots. These have a neuroendocrinal component of a cell of origin, and very enhancing, very vascular tumors. But the key is to look at the vascularity associated with it. Like look at all the collaterals that come to supply this tumor. And according to the WHO Grade 5 classification, they have its own category within the paraspinal tumors. They're called now the cauda equina neuroendocrine tumor, previously called the paraganglioma. And then you can have teratomas, right? Basically, two or more lines of cells, totipotent cells from either ectoderm, endoderm, or mesoderm. They come to rest in these regions, and then they grow, right? That's a teratoma. Now, here's an example from the literature of a holochord panmedullary mature teratoma in an adult male. And as you can see, there are lipomatous components on this T1 weighted image throughout the spinal cord. This was present throughout the spinal cord, and this was a mature teratoma. So basically, it had components of, ectoderm and endoderm. Now, so far we talked about the purple category, right? The purple bucket, where we talked about everything within the pia mater. Now we go outside the pia mater, but we still stay within the dura. So that's the intradural extramedullary compartment that we're going to talk about. These can arise from the Schwann cells of the nerve roots, from the arachnoid cap cells that are embedded in the dura. It can arise from dural and pale fibroblasts, and of course, metastasis can go anywhere, right? Anywhere in the spine, anywhere in the body. The most common ones that you're going to encounter are going to be nerve sheath tumors and meningiomas, especially in the adult population. But in general, all the different types can be schwannomas, neurofibromas, perineuromas, hybrid nerve sheath tumors. You can have malignant melanotic nerve sheath tumors, malignant peripheral nerve sheath tumors, cauda equina, and then the cauda equina neuroendocrine tumors. Now, all of these are the paraspinal tumors. According to the latest classification, they fall between grades 1 through 3, depending on the cellularity of that tumor. So nerve sheath tumors, these are the most common ones that you will encounter, right? And usually they can be seen in the cervical, thoracic, or lumbar spine. Some of these, they're typically in this category, the middle category, the green category, right, which is intradural extramedullary, but some of them can have some extension with an intramedullary component, basically that kind of insinuate into the cord in itself. Now, here's an example of a neurofibroma in a 40-year-old. And as you can see, these are typically dumbbell-shaped tumors, right? They're like a dumbbell because they arise in that area where the nerve root is coming off. And so where can they grow? They can remodel that neuroforamen, the osseous neuroforamen. They can make it wider, but there's not enough room to grow. So they grow inside and outside, so giving that classical dumbbell shape appearance of the tumor. Here's a nice enhancing neurofibroma with that classic dumbbell-shaped appearance. This is a T2 lesion, so it's pretty T2 bright. And then it is enhancing a sort of a little heterogeneous, you see, but predominantly homogeneous in appearance. And see how it's pushing that spinal cord to the side. Because it's a slow-growing tumor, it slowly pushes the cord and slowly expands that neuroforamen. Here's another example of a schwannoma. Now, in a 22-year-old male, as you can see, this is on the patient's left side, and it's expanding, unlike the right side, which is a normal neuroforamen. You see how this has slowly remodeled that neuroforamen and has expanded it and has pushed the spinal cord to the side as well. Now, that's an example of another schwannoma. And schwannomas are very T2 bright, and then they have this heterogeneous appearance within them as well because of all that, Anton A, Anton B areas. It forms that heterogeneous appearance inside a schwannoma that we kind of see here. Now, here's another example of a schwannoma. This is a sacral nerve schwannoma, right? So it arises from in the S2 region, the S2 nerve root on the right side. Now, in a 45-year-old female, that's a schwannoma. Here's a plexiform neurofibroma. So it arises from the the brachial plexus, right? And as you can see, it's involving multiple nerve roots. And then it's like a mesh of multiple nerve roots, and it's along the nerve sheets of multiple nerve roots. And it's presenting, as this enhancing large tumor that's going to affect multiple nerve territories, right? And then again, it's a very bright tumor again. And it has that very finger-like projection because it's along that brachial plexus. Okay, so here's one along the lumbosacral plexus. As you can see here on the left-hand side of the patient's left side, radiological left side is this big, complex, lobulated tumor that's arising from the nerve sheets of multiple of these lumbosacral nerve roots forming the lumbosacral plexus. And so that has insinuated into the psoas muscle, into the posterior paraspinal muscles, and right, like it's that big tumor. And here's an MRI showing the same thing. It's an IC2 bright tumor that's kind of insinuated itself into the muscles adjacent to it, and the tumor in itself centered in the lumbar plexus. Nerve plexus. Okay, so that was in the middle bucket. Another commonly seen lesion is going to be our meningiomas, right? So meningiomas tend to occur most commonly in the thoracic region, less commonly in the lumbar region, but we do have examples of meningiomas in the lumbar region as well. And then you will also see that in the craniocervical junction. So in the craniocervical junction, of course, we have to be careful because it can invade the vertebral artery, and meningiomas are tough fibrous tumors. So when they invade, when they surround or encase, I should say, not invade, but in they encase an artery, they tend to constrict the artery. And as we can all imagine, when the artery gets constricted, a patient is going to have symptoms related to stroke. So that's something to keep in mind when you look at the craniocervical junction meningiomas. And in patients with neurofibromatosis type 2, they can have multiple meningiomas throughout the spinal cord, and of course intracranially as well. So histopathologically, there are about 15 subtypes, but usually WHO grading gives grades 1 through 3. The clear cell and the chordoid types are going to be grade 2, and it's all molecularly refined now with molecular typing according to WHO classification. So you're looking for all these types of molecular typing to stratify these meningiomas. Unlike the previous histopathological types, this is more important or more popularly used these days because of the molecular typing of meningiomas. Now, and it's used for grading the meningiomas as well in lower grades versus higher grades. Now, here's a meningioma in a 50-year-old. This is a T2 image. As you can see, it's along the side here. It's occupying that intradural space, but it's outside the cord. So that is the cord that's slightly pushed to the side, and these are enhancing tumors. So I apologize for the quality of the image. It's a little blurry because of motion, but as you can see, there is some enhancement associated with the tumor, as with which the tumor is well defined and beautifully seen here. And these tumors tend to have something called a tail, like a dural tail. As you can see, that's the dural tail. So because it arises from the dura, it kind of grows along the dura and makes that little tail. That's a meningioma. Here's another example of a meningioma, nicely circumscribed tumor. And as you can see on the T2 images, these are not bright. these are kind of darker because they're like tight and nice and fibrous tumors. They tend to be darker on a T2 than your nerve sheath counterparts, right, which tend to be brighter. So these darker tumors, and as you can see, this tumor is actually compressing the cord. And here's that darker area, that crescent is actually the spinal cord that's been so compressed by this meningioma here, this enhancing meningioma in the 70-year-old female. Here's another example. Like I said, lumbar is not a very common location. So here was a tumor which is kind of T2, like intermediate to darker in appearance, although this is a common location for a myxopapillary ependymoma. But it was more darker and it was more solidly enhancing, unlike that cystic, didn't have any polar cyst, didn't have hemosiderin. So it behaved like one, and it actually ended up being a meningioma as well. Okay, so what else can be in this compartment? Like I said, Mets can be in this compartment. So here are examples of metastasis in a patient with medulloblastoma that tend to be that ended up being in this location. So these are all like multiple deposits of metastatic disease in this intradural extramedullary location in a 2-year-old with medulloblastoma. Now, here's a 60-year-old with prostate cancer. And as you can see, there are all in this location, there are metastatic disease as well that happened to be in this patient with prostate metastasis. And then here it is in the sagittal view as well. And so that was the second bucket of tumors, right? The extramedullary but intradural location. Now we have dura. Now I'm going to talk about everything outside of the dura. So everything extradural. So the major anatomic structure is going to be the bones, right? The osseous ones. These are going to be the extradural tumors, and depending on the origin cell, it can be of different types, right? It can be osteogenic, chondrogenic, vascular, hematopoietic, could be notochordal, again, giant cells, or Ewing sarcomas, right? So depending on that, it's either benign category or malignant category. You have all of these. We don't have the time to go in depth and cover every single tumor in the extradural compartment. But I would like to say, especially in the adult population, metastasis is the most common extradural tumor in this location, right? So it's usually lung and liver mets that you tend to see. And then, the marrow can be taken out for sampling, and then you can get the actual pathology, is the actual cell origin of the metastasis. They tend to cause like pathological fractures. So as you can imagine, now the cells are being replaced, right? The bone marrow is now being replaced by these tumor cells. And so they're not as stronger anymore. And so they tend to fracture, they tend to compress and fracture. So that's known as a pathological fracture, right? And so because of that pathological fracture, as you can imagine, it's going to go and push the adjacent spinal cord, can have mass effect on the spinal cord, right? And things like that. And then the Mets can be bone forming, or they can be bone lysing tumors. So they can be lytic in appearance, or they can be sclerotic in appearance on CT, or sometimes they can be mixed both. They can lyse tumors in certain regions, that they can be bone forming in certain others. So it can be mixed. So most common ones are going to be prostate, breast, non-small cell lung cancer, hepatocellular cancer, renal cells, and thyroid cancers. So bone metastasis, spinal metastasis is going to be the third after lung and primary liver cancers. So metastasis, here's an example. In a patient with RCC, renal cell carcinoma, as you can see, it has completely occupied half of this vertebral body and replaced the bony elements. It's a CT, and you can see the occupied mass. And here, the L5 vertebral body, it has not just occupied it, right? But it has also resulted in weakening of that bone. It has resulted in a compression fracture deformity. That's a pathological fracture deformity. And as you can see, all the retropulsed, the tumor components have kind of like the smushed vertebral body has now gone into the canal, and it's going to cause mass effect on that cardiac vena nerve roots over there, right? Now, here's another example. Now, this is an example of lymphomatous origin tumor. So here's a lymphoma that's kind of eating away the actual bone. And when you do a PET scan imaging, you can see it's kind of lights up. It's very metabolically active tumor on the PET study. Here's another example. It's another example of renal cell carcinoma metastasis. See how it has like caused so much of weakening that the bone is actually, the vertebral body is kind of pathologically compressed here in this patient. And all the tumor components are being now pushed into the thecal sac, into the canal, and causing compression of the thecal sac and the spinal cord. Now, this is an example of a renal cell carcinoma. So when you talk about these tumors compressing this, the canal and pushing into the canal and compressing the spinal cord, there's a little grading system called the um, epidural spinal cord compression scale. Now, why is that important? So here, this grading system kind of tells you how much is it compressing the tumor. This one, 0 is like absolutely nothing. Grade 1 is a little bit. Grade 1, that's 1A, and then 1B, it effaces partially the thecal sac. Grade 1C, it effaces not just the central CSF space in the thecal sac, but it also touches the cord. I tell my trainees 1C, C for cord. So it touches the cord. And then grade 2 and grade 3 is grade 2 is it's more than touching the cord, also starts deforming the cord, but there's still a little bit of CSF left. And grade 3 is when there's basically no CSF left, and then the cord is like really tightly compressed. So why do we use this? So it kind of gives the surgeons and the radiation oncologists a sense of how to treat the tumor. So grade 0, 1A, and 1B, they can just radiate the tumor and have good results. But then beyond that, 1C is depending on the tumor and depending on the location and depending on the patient, decide on whether to surgically also intervene or just do a radiation treatment. Whereas for grade 2 and grade 3s, we are going to be doing both both surgery as well as radiation treatment. Okay, so quickly a word on the osseous venous malformation. This is more commonly incorrectly known as hemangiomas, osseous hemangiomas. These are actually just venous malformation. These are hematomatous vascular tissue. They have a very classic polka dot or corduroy pattern. And then they can actually extend outside of the actual bone and then can go into the epidural space. Now, here's that nice classic corduroy or polka dot appearance, because you start seeing the tumor with that slight fatty content in the matrix, and then you see that struts of bone. That gives that polka dot appearance. And these also can result in pathologic compression fractures. As you can imagine, it's replacing the actual bone. And so because of that, it's weakening the bone. You can have pathological fractures. You can have epidural extension, so meaning that it's not just now confined to the actual bone, but it's starting to grow into the canal. And so now it can result in mass effect in the spinal cord. Here's a 30-year-old female with this osseous venous malformation extending into the canal and causing some mass effect on the spinal cord. Okay, then notochordal elements can, give rise to these chordomas. They can arise more commonly in the cervical, and then followed by lumbar, and then the thoracic region. It has a wide range of age distribution, and majority of them, 30% of them are in the vertebra. And then symptoms are because of the mass effect of the tumor in itself. Now, here's a chordoma. It was in the cervical region. And as you can see, it's almost looking like it's a very T2 bright tumor. But as you can see, it was kind of also remodeling the, neuroforamen. And that's actually it was arising from the notochordal remnant of the vertebral body, and started growing into that neuroforamen area. So there are several primary osseous tumors from osteoid. We saw a list based on the origin of the tumors. We won't be able to go into the details of all these primary osseous tumors. But something to keep in mind is that some of the tumors mimic, like metastasis can mimic primary osseous tumors. For instance, aneurysmal bone cyst is very well known for its fluid levels. Now, here is an RCC, like a renal cell carcinoma, that went and metastasized a vertebral body. And it has so much of hemorrhage that it started causing like this fluid level. So it can mimic an aneurysmal bone cyst. Now, here are examples of osteosarcoma with that cloudy matrix. Here's an example of a chondrosarcoma with a cartilaginous, like rings and arc kind of a matrix. So these are just examples of tumors. I'm sorry, we don't have time to go into the depth of the osseous, primary osseous tumors. It is for another time. And always, so whenever we are looking at spinal cord tumor, it is not a classic, presentation all the time. It's not very easy to identify what type of tumor it is because there are other differentials in your consideration, right? Sometimes demyelinating lesions such as multiple sclerosis, NMO, neuromyelitis optica, ADEM, and MOG, myelin oligonucleotide type of demyelination can also result in patterns that cause cord edema and can appear tumor-like. Sarcoidosis can look like tumors. TB infection can look like tumor. Enteroviral infections can look like tumors. Sometimes ischemia with that edema can also mimic a tumor. So I'll have to keep all these differentials in the mind. So it's always a full picture with the clinical exam and like all the blood work and everything. It's a holistic approach. But I hope getting a list of categories to think of when you look at spinal cord tumors sort of helps you. So today we looked at, three main categories of spinal cord tumors. We looked at the actual cord per se. Everything within the pia mater was the intramedullary component. And then we saw meninges giving rise to tumors. So that was the intradural extramedullary component of tumors. And we saw extradural components. We saw and I hope that helps you. And I think we are on time. And thank you very much for your patience. And I'm very, very glad to answer any questions if you have. And this is where I work.
Thank you very much, Dr. Priya. That was a very exciting and insightful topic. And you really came down to our level. My residents are so happy about your lecture. It was so informative. Please, if you have any questions, put them in the Q&A section and I will let Dr. Priya answer the questions for you. But for my residents, if you have any questions, you can just unmute and give us your questions. Dr. Priya is all ears for you. You can come back closer. Dr. Priya, looks like my residents have some questions for you.
All right.
Dr. Priya, thank you for that detailed presentation.
Thank you for listening.
Okay, I wanted to ask you if we encounter a patient that can have MRI because it's contraindicated, which of the other modalities can help us get a definite diagnosis of a spinal cord lesion like this one?
Yeah. Yeah, that's a great question. So typically when MRI is contraindicated, we obviously first start off with CT. We look for any osseous, remodeling. We look for lytic sclerotic lesions, and then but it doesn't give us a great look of the actual canal contents, right? So you want to look at the spinal cord, which is going to be very challenging. So we tend to do CT myelography. So what we do is under, CT guidance, so we actually inject contrast into that thecal sac, into the CSF, just like a lumbar puncture, we inject contrast, and then it kind of coats everything around the cord. So when you have that either Omnipaque or one of these contrast agents, and that's like coating the entire CSF space, you have the patient on the table kind of do all sorts of maneuvers to make sure that it kind of surrounds the entire cord from cervical all the way down to lumbar, and then you image. It kind of is a mimic for T2 imaging on MRI. So that kind of will give you an estimate of how much of expansion there is, but it won't give you the details of the actual tumor though. But it can give you something as to the size of the tumor. It can tell you if there's a myelographic block, meaning like, oh, the CSF is not able to pass across the tumor. So, it's a big tumor. And then the definitive diagnosis is going to be through a biopsy and then looking at the histopathology of it. But that's just a rough estimate of what we can do with, make do with, CT when we don't have MRI. But that's a great question. Do you guys encounter that often?
Yes, sometimes. Yeah.
That's an
Okay,
area.
there's a question in the Q&A. Says that thank you, Dr. Priya, for a wonderful section. We're looking upon the tumors part from those that have a typical pattern. How do you narrow down the differential on the tumor per se?
So if I understand the question, so basically how from
He's saying that we're
if you
looking
don't
upon
have
the
typical.
tumor part from those that have a typical pattern.
Got
So
it.
how you narrow it down?
Yeah. So when we don't have the typical pattern, it's going to be a differential. So you always try to see if you have a typical pattern, but the real world scenario is not going to be so easy. Not all tumors read the textbooks and come and present. So they have their own variations. So it's kind of challenging, when we do so we have a multidisciplinary conference. We have it once a month at our institution. So where we have the spine surgeons, radiation oncologists and neuropathologists, they all are sitting in the conference. And so we all try to analyze what that tumor could be. So the tumors the patients that don't read their textbooks and present differently, we all need everybody's head together. And then we are like trying to figure out, oh gosh, could this be this? We think it's most likely an ependymoma, although it's not very classic. It doesn't have a hemosiderin cap or something like that. And then of course, we kind of alert our team. And then the neuropathologist has at least a small differential where we rule out more important things that we can rule out, and then we narrow our differential to a smaller list, and then we go from there. And of course, biopsy is going to help us. So sometimes even biopsy doesn't help. So, yeah.
Okay, I think one of my residents still have a question for you.
Okay.
Thank you very, very much, Dr. Priya, for the lovely presentation. Talking of the tumors that don't read the textbooks, conversely, for the classical tumors, let's say for the intramedullary tumors, if you see an eccentric tumor that you think is an astrocytoma, or if you see one that is central, I wanted to know if you have any values or any validated studies that tell us the concordance between the classical radiological features and the findings at histology. And if there are any things that are, say, pathognomonic. And lastly, if that's kind of insulate you from any lawsuits, if you are thinking that it's an astrocytoma and it ends up being an intramedullary metastasis.
So in terms of radiology, for the last part was very exciting because it's lawsuit, you're saying. So usually when you look at a tumor, and I think the features are suggestive of an astrocytoma, then I would say, suggestive of an astrocytoma. And yes, it could be an intramedullary metastasis, but I'm hoping that the age group is going to help, right? Like younger population tends to be more of an astrocytoma. And for instance, I did show an elderly female in one of my slides who had this like very enhancing intramedullary lesion, and then she was in the classic category for the pediatric astrocytoma. So astrocytoma was not our differential. And it came to the multidisciplinary conference. So we were all like worried that it was metastatic disease. It was intramedullary metastasis. And then so we did that patient ended up having a PET scan because we were trying to find a primary. We were like, it's more likely a metastasis. And then we didn't find any primary. And this patient only had that very hypermetabolic lesion on a PET CT, and then came to the interdisciplinary conference, and we are like all thinking, oh, it doesn't look like it could be an astrocytoma, I guess, but probably it's metastasis, but we don't know the primary. And then it ended up going to a biopsy, and biopsy came back as a grade 3 astrocytoma. So yeah, these things do happen, but I mean, we're all doing it in the best interest of the patient. We're giving our educated guess. So I hope it doesn't end up being a lawsuit for anybody. Hopefully. But that's pretty much the pattern we follow. So there's always a chance that you are wrong. And that's part of radiology, that's part of pathology, that's part of everybody's life, where you do your best educated and calculated guess and hope you're right. Um, but yeah, things can go wrong. And that's when it comes back to the next session. Hey, remember where we all thought it was metastasis? It was actually not one. It's like, thank you very much. That was a very humbling experience. Thank you. So it happens to all of us all the time.
All right. All right. I think we have more questions for you.
Hi, Dr. Priya.
Hi.
I wanted to know, in your experience, which of the tumors are common or the commonest ones you encounter?
Yeah. So metastasis. That's always the most common that we encounter. And then in terms of the the other category of tumors, I would say the next most popular are going to be I shouldn't say popular, the most common ones are going to be meningiomas and nerve sheath tumors. And then we see the rest. The intramedullary ones are very less frequent than the rest of the ones. So metastasis, especially the bony metastasis, these are very, very common. And osseous venous malformation, hemangiomas are actually our trainees really love to report that. This out appearance, most likely represents an osseous venous malformation. So that's also a common one. So METs and osseous METs and osseous venous malformations are common. Then meningiomas and nerve sheath tumors are more kind of the next category, I would say. And then intramedullary tumors are the third, frequent category of tumors that we encounter here. How about yours?
Okay, so there's another question here in the Q&A section. How do you differentiate prostate bone metastasis from a severe degenerative fatty changes of the spine for a biopsy-confirmed prostate carcinoma?
So is it a biopsy confirmed? Is the biopsy of the prostate, or is the biopsy
Yes,
the bone lesion?
the biopsy of the prostate.
Oh, we could always do the best way to differentiate, obviously, is to send it to our pathology colleagues, right? You take a piece of that, you take a piece of that bone and then send it to them, say, what does it look like? But so that would be the best way to differentiate. But then when I think of prostate mets, I'm thinking of a a very sclerotic lesion, right? A bone-forming lesion. That's what prostate bony metastasis is going to look like. And then sometimes you have bone islands that kind of mimic. And especially if there is a patient who has prostate cancer, then you're like, oh my goodness, what is this? Is this a prostate met, or is this a bone island? And you try to see far back. So there are cases like this that commonly happen. And so there's a patient who had a prostate cancer, and then the CT scan was done, and then there was a bone, very sclerotic lesion. And then our question was like, oh, is this actually a metastatic bone metastasis from the prostate cancer, or was this just a bone island to begin with in this patient? So we go through the chart, and then we actually found that the patient had a scan done about 15 years prior, and that CT actually had that bone island already in it. So thankfully we were like, oh gosh, it's exactly looking the same 15 years ago when the patient did not have any cancer. So this is just a bone island, so things like that can help if we are lucky. But if not, always get our pathologist help. Take a biopsy, and that's the way to do it. Oh, Yeah, and some people look at the density of it too. Like a Bone Island's density versus the Hounsfield unit's Bone Island's density versus prostate met density differs. So that's another way to do it. But yeah, the most definitive way would be to biopsy that actual met if possible, and then send it to pathology. But
Yes,
great questions.
one from Tombi Villakazi. He says that, how often do you see spine lymphoma and spine tuberculosis?
We tend to see spinal lymphomas it's not very, very common, but we have a handful of cases, I would say, in the last few years in younger population versus to older population. We have seen spinal lymphomas. They present with these like areas. Sometimes it can be hard. So one patient I remember presented with all this destructive appearance of the bone from lymphoma and ended up having extensive enhancement going into the spinal, in the canal in itself. And it was actually read as, possible discitis osteomyelitis in that patient. And then it came to me for biopsy. And so I ended up biopsying a part of the disc and part of the bone. And then it ended up being a lymphoma. So you can have a very similar destructive appearance with all that enhancement and everything too, which can mimic a lymphoma. And tuberculosis is not very common in our side of the town. And so we do see rare cases of tuberculosis. But lymphoma is more common in our scenario here.
Thank you. Our
Yes.
last question. Just
Yes,
one
yes.
last for my
Yes.
resident.
Thank you very much, Dr. Priya. Your presentation was quite enlightening, and you had a lot of interesting images on it. There was one that made mention that we should be careful, especially there was one in the spine that looked like an aneurysmal bone cyst, an ABC, but you said it was a spine, a form of a metastasis. Now, my question is, for the purpose of the kind of spotters we use when studying and whatnot, is there a way to probably differentiate just based on the image rather than assuming we didn't have histopathology to go with it? Thank you.
Yeah. Very good question. So in this case, so this was one case. We had another case recently, very same presentation where there's so much of hemorrhage in the renal cell met that there was way more enhancement, and then there was way more hemorrhage within it than an aneurysmal bone cyst, which was a little more cleaner in appearance. I don't know how much that helps. But the second thing I would say is aneurysmal cysts just don't grow just like that. In a spotter case, it's going to be challenging. But for me, the way we thought about it was this patient luckily had a scan done before that did not have this lesion. And then suddenly, within a year, had this like really large lesion with so much of fluid levels that it, obviously it pushed it towards something that grew very fast, and it's going to be a metastasis. So it was a renal cell carcinoma. And the very interesting thing about that was like this patient also, if the spotter, if they're very kind enough, hopefully they open the window a little bit and show you a kidney with the lesion there to show you there's a renal cell carcinoma there. But it's very challenging. So this patient, we just had one last month, another case different from the one I showed, had all these fluid levels, but this is a lesion that grew so fast. And then the renal lesion in itself was so hard to find. We couldn't even find the actual renal lesion on imaging, but this was a renal cell met on pathology. On pathology is when we found out this was actually a metastatic disease. We knew it was going to be a metastatic disease because it grew so fast, but we didn't know where it came from. And then it was on histopathology that we found that it was actually renal cell origin. So to come back to your question, on a spotter case, I hope your examiner is kind enough to show you a kidney cancer right next to it. But But other than that, I don't think it's very, very clear cut. I would say maybe more enhancement, more hemorrhage and necrosis, point more towards renal cell carcinoma, and then that's little renal cell cancer on the side, or the fast growth. These are the things I would think of.